Hello, I'm David Kerr, Professor of Cancer Medicine at University of Oxford. And today I'd like to talk a little about, let's call them unintended consequences. And I'd like to illustrate this with a patient that we've looked after for many years and who is that we're looking after currently in the clinic. For more than a century, there have been empirical clinical observations that resection of a primary tumour, may cause an increase in growth of any residual microscopic metastases, implying was in some way that there were tumor-associated factors, such that when the tumour was removed or debulked, these repressive factors were removed, releasing the brake, as it were, causing a growth spurt in any residual disease that may have been left behind. Quite a controversial area, and arguments both for and against this conceptually. There's quite a lot of more recent mouse data suggesting actually that resection of a primary tumour can cause regression of at least some tagged micrometastases. So an area of huge controversy, but one that keeps cropping up. The sorts of factors which are considered to be important, how could surgical debulking of tumour, how could that be associated with growth of residual disease? Some of the factors may be to do with the perioperative state, the stress of surgery, the inflammatory insult of surgery. People have quoted psychological stress associated with debulking, the extent of primary surgery. There may be neuroendocrine and paracrine factors. We know that following any major operation, there can be sweeping changes in levels of cortisol, prostaglandins as part of that pro-inflammatory change, and so on. Immune factors. There's a lot of work done looking at the immediate post-operative changes in the immune system, usually being weakened. We see pro-metastatic immune factors increasing, tumor-associated macrophages, increased blood levels of IL-8, IL-6, anti-metastatic immunity is decreased, reduction in NK cells, IL-12, IL-10. These have all been documented and correlated loosely with that, if you like, an anti-metastatic immunity being decreased by the impact of surgery. And of course, there's always a possibility of the changes in growth factors, increase in TNF-alpha, post-surgically, a decrease in anti-angiogenic factors like endostatin, increase in pro-angiogenic factors like VEGF. So of all set of plausible circumstances that could be associated with a flare of growth and residual disease. Our patient, we looked after with her for 5 years, and she came initially with synchronous hepatic metastatic disease. This responded very well to conventional chemotherapy, allowing us to reset the 4 hepatic metastases that were demonstrated and the primary tumour. She was well for 18 months or so, then had a recurrence in a retroperitoneal lymph node isolated, and we gave SABRE treatment. We gave focused radiotherapy treatment from this, and she remained well. Scans normal, biomarkers normal, CEA, CA19-9 for another 12 months. Then she had a recurrence within the pelvis, nodes, a plaque of tumour sitting behind the bladder, 1 or 2 other peritoneal nodules, liver, lungs completely clear, with a rise in marker CEA. We gave chemotherapy, second-line chemotherapy, and again, a decent response, a decent partial response. And she wanted to go ahead with pelvic exenterative surgery, major operation, including retroperitoneal lymph node dissection. She underwent this successfully with clear margins, but within 2 months of what was a major operation, requiring a colostomy, requiring a urinary diversion because a bladder was taken, of course, as part of this major surgical procedure. Her first visit back to us post-surgically 2 months later with a scan so that she had multiple, more than 15 hepatic metastases. Now, of course, these microscopic metastases would have been there. We resected the macroscopic disease that we saw all those years ago. But it just brought me in mind of that sense of unintended consequences of having through a truly life-changing major operation requiring plastic surgery and so on. And after such a short period of time, to come back with such devastating news. And of course, now a very limited lifespan. We're managing her with chemotherapy just now. Too early to say yet if it's being affected. But it did bring me in mind of that story, that sense that if we debulk primary disease, this may have this reflexive negative effect in terms of promoting more rapidly a growth spurt in any residual microscopic disease. I'd be very interested to see what you think of this. It's an area of huge controversy. The data are plausible but not compelling. The experimental data from murine models is variable. But I just wonder if any other of you practicing clinicians have come across anything similar, or if you have any strong feelings one way or the other. I'd be very interested in your opinion. Thanks for listening as always, but for the time being, Medscapers, over and out. Thank you.